So let's talk a little bit about postural homeostasis, reflexes, deep tendon reflexes. Again, our lower motor neuron, that cell body begins in the anterior spinal gray matter, and that neuron goes out and activates the muscle. So when that lower motor neuron fires, that action potential causes a release of acetylcholine and the muscle contracts. Well, something else that muscle has is a sensory receptor, a stretch receptor. It's a neuron that senses the stretch of the muscle. And so when that muscle is stretched, that sensory neuron fires and sends an action potential. And that sensory neuron also terminates onto the lower motor neuron. The lower motor neuron gets all sorts of signals that it has to balance and put together to fine-tune muscle movement. So here our stretch receptor is signaling the lower motor neuron to fire. So when the sensory neuron is stretched, that causes the lower motor neuron to fire and compensate for that stretch. And that's what deep tendon reflexes are. If you take a hammer and tap on somebody's knee, their patellar reflexes, you tap on that ligament right below the tendon, right below the knee. It stretches the leg muscles and they contract, causing the knee to kick, the foot to kick out. That's a deep tendon reflex. And what's happening is a stretch receptor is being activated and it's signaling the lower motor neuron to respond. And so you can tell lower motor neurons get all sorts of information about how to move muscle from all sorts of systems. The reason that this occurs is so that reflexes can occur directly at the spinal cord, and that saves time and that increases complexity. If the upper motor neurons went straight to the muscle and all the sensory systems went up to the brain, it would take us a long time to respond to things like falling over and putting our hand on a hot stove. And so by these reflexes occurring at the spine, they allow for instantaneous reflexes without us having to think about it at all. So if you think about it, when you stand up, if you just stand there, your muscles aren't completely relaxed. Those stretch receptors and lower motor neurons are constantly making adjustments so you can stand upright without even thinking about it. Those deep tendon reflexes are part of our postural homeostasis, standing upright without falling over. So let's talk about why upper motor neuron injury results in hyperreflexia, over reflexes, excessive reflexes. Somebody who has upper motor neuron injury, either to a brain or spinal cord injury, their deep tendon reflexes are going to be accentuated. They're going to have hyperreflexia. And so remember, lower motor neuron is what moves muscle. And we have a picture of that here. I'm going to make it simpler on myself and show you the lower motor neuron here in green activates the muscle. And so the action potential from the lower motor neuron activates or excites the muscle, and that's what that positive sign down there is for. Well, the upper motor neuron that comes from the primary motor cortex and down into the spinal cord, it activates lower motor neuron. Upper motor neuron excites lower motor neuron, and that's what that positive sign is. So if you notice on the left, the stretch receptor in yellow also excites the lower motor neuron. But to do deep tendon reflexes, the person needs to be completely relaxed. Why? Well, that upper motor neuron, it excites the lower motor neuron, but something else the upper motor neurons do is they block all of the other reflexes. And so when your brain is trying to control motor movement, when the primary motor cortex is controlling motor movement, it blocks all of the other signals trying to signal the lower motor neuron. And so that's why we see a little branch coming off the motor neuron with a little negative sign, because it's trying to block the influence of that stretch receptor. The upper motor neuron is trying to block all of the influences on that lower motor neuron, so the lower motor neuron will only listen to the upper motor neuron. And so even though the upper motor neuron excites lower motor neuron, upper motor neuron blocks all of the other reflex pathways trying to signal the lower motor neuron. Well, if we have upper motor neuron injury and that upper motor neuron is lost, something else that's lost with that upper motor neuron is the inhibition on all of those other reflex pathways, including the stretch receptor. So with somebody with upper motor neuron disease, they're going to have hyperreflexia, spasticity, hypertonicity, because their lower motor neurons have lost the inhibition preventing all those reflexes from taking over the lower motor neurons. All right, let's talk a little bit about seizure. Some receptors in your brain are excitatory, and excitatory means the signal causes action potential. So when one neuron excites another neuron, the one neuron causes action potential in the other neuron. If we think about the neuromuscular junction, where the lower motor neuron communicates with the muscle, that's excitatory. When the lower motor neuron fires, the muscle is excited and causes action potential. But think about this. Most of the connections in your central nervous system are inhibitory, meaning preventing action potential. Notice, as you sit here and watch this lecture, your upper motor neurons are not firing, other than a little bit of fidgeting that we all do. If you think about it, your upper motor neurons are kept quiet a majority of the time. And so a majority of the connections in the central nervous system are inhibitory. And these inhibitory systems use GABA, gamma-aminobutyric acid, as a neurotransmitter because GABA opens chloride channels. So if you think about all your upper motor neurons firing all at the same time, then you can imagine what's going on with somebody who's having a grand mal seizure, because it's the failure of these inhibitory systems, these inhibitory neuron connections, that result in seizure. So GABA, gamma-aminobutyric acid, opens chloride channels, and opening chloride channels inhibits a neuron from firing. Why? Well, remember, opening sodium channels is what excites the membrane. So opening chloride channels, that negative charge on the chloride completely offsets the positive charge of the sodium. So the sodium cannot cause a voltage change across the membrane. This is how opening chloride channels inhibits neurons, because that negative charge of the chloride cancels the excitatory positive charge of the sodium, and that sodium causing a voltage change is what excites the membrane, and so opening chloride channels cancels that out. That's why GABA is an inhibitory neurotransmitter by opening chloride channels. And I think I've made this point. Remember, in the gray matter of the motor cortex, there are these pyramid-shaped cells, and these large pyramidal neurons are surrounded by little teeny tiny inhibitory neurons called interneurons. And so these pyramidal neurons are big. They have big pyramidal-shaped cell bodies. They begin in our gray matter of our primary motor cortex, and they go down the spinal cord. But they're surrounded by all sorts of little teeny tiny neurons whose axons are not any bigger than a millimeter or so. They're completely surrounded by these little tiny interneurons. These tiny interneurons keep the big neurons quiet. So large active neurons are constantly surrounded, completely surrounded by tiny neurons, and they keep the large neurons quiet. This failure of inhibition results in seizure. And again, here's a picture of a big large neuron, and it's surrounded by little teeny tiny neurons that are firing and keeping the big neuron quiet. And if something happens to those small interneurons to where they're not able to keep the large neuron quiet, this is going to result in a loss of inhibition, and this is going to result in excessive firing, especially of upper motor neurons, and that's what we see in grand mal seizure. So these small inhibitory neurons use GABA, gamma-aminobutyric acid, as a neurotransmitter. And so when you talk about seizure disorders, you're going to talk about the treatment of seizure disorders, and many of the treatments include drugs that are gamma-aminobutyric acid, GABA, agonists, like diazepam, Valium. All the benzodiazepines are GABA agonists. Phenobarbital is a GABA agonist. And look for anti-seizure drugs, anticonvulsant drugs that have the words GABA in them, like gabapentin, Neurontin, which is an anticonvulsive medication as well.